Good evening, friends. This is Dr. Kanagwel, the convener of the IAGES Prime Time, speaking to you this evening. A very good evening to all of you. I'm happy to have you on board the member surgeons fraternity of IAGES and the entire surgical fraternity in and out of the country. Thank you for joining us this evening. May I have the honor of welcoming our president, Professor Sunil Papat. For those who are yet to know Professor Sunil, he is an eminent foregut surgeon with special interest in endoscopy and endotherapy. And he also has a special interest in bariatric surgery. Dr. Sunil Papat has been taken up the leadership in a very challenging time. And he has been taking the IAGES through greater heights during this difficult phase of corona pandemic. This IAGES Prime Time has been conceptualized and it has been happening for the last 1 year, and it has been welcomed across the country and across the globe. We have eminent surgeons who have spent their lifetime in learning, perfecting, and educating the surgeons of the younger generation to a particular surgical skill to share their wisdom, their experience, and then their perfection strategies for a good outcome. With that in mind, this program is created. I now have the honor of inviting our president, Dr. Sunil Papat, to welcome the guests and welcome the fraternity who have joined us this evening. Professor Sunil Papat, please.
Thank you, Dr. Kanagwel, for the kind words. Good evening, dignitaries, and good evening, friends. Good evening, IAGES members. I am very happy and privileged to welcome you all to yet another exciting episode of IAGES Prime Time. IAGES has started Prime Time since last 1 year, and every fortnight we are doing this program, and we are so lucky to have eminent faculty today in the form of Professor Chih-Kun Huang. Professor Huang from Taiwan, on behalf of IAGES, I'm very happy and pleased to welcome you to IAGES Prime Time, which is a landmark program for IAGES, and it's happening every fortnight. I'm very happy to say that this program is being watched not only in India, but across the Asia, Europe, and Australia and America. And many of our friends and colleagues regularly join and encourage us and participate in this academic activity. During this second wave of COVID pandemic, in the last 4 to 5 months, we have not been able to do any on-site program of IAGES, but IAGES has been very active in virtual programs in the form of fellowship in essential surgery, FIAGES, fellowship in endoscopy, GI endoscopy, EFIAGES, and last month we have started pulse oncology online also. Friends, I am very happy to share with you that in majority of the states of India, the COVID pandemic has died down, and in some of the states it is officially declared that the second wave of the pandemic is over. Our colleagues and our friends and our dynamic EC members have lined up so many programs for the next several months. And I'm happy to share that in September, to have False Upper GI program in Delhi, being organized by Dr. Randeep, Dr. Deep Goyal, Dr. Sandeep, and their team. False Upper GI is happening. It is being organized by IAGES since last 4 years, and it covers the upper GI surgeries of esophagus and stomach, both benign and malignant, as well as the bariatric surgeries. And this program has become very popular, and it is very much sought after by the laparoscopic surgeons. In the later part of September, we are doing FIAGES and EFIAGES combo, being organized in Chennai by convener of our prime time, Dr. Kanagwel. Dr. Kanagwel has been very active in IAGES activities since last many years. He's a true academician and has been at the forefront of organization of many programs in IAGES. Dr. Kanagwal, on behalf of IAGES, I thank you. I'm very pleased to welcome my dear friend and our immediate past president, Dr. Raman Goyal, who is moderating this session today. Dr. Raman Goyal is an eminent bariatric surgeon from Mumbai and has been editor on the editorial board of the several journals across the globe. Friends, I have been given the proud duty of introducing my dear friend Chih-Kun Huang. I was very happy that Professor Huang was here in Ahmedabad to participate in IAGES 2012 in February 2012, and that was our first interaction. 9 years have gone by, and I am very happy to say that Professor Huang looks only younger. So welcome to IAGES again, Professor Huang. He is a superintendent of Body Science and Metabolic Disorders International Medical Center, China Medical University Hospital, Taiwan. He is on the board of directors, Taiwan Obesity Support Association. He is founding chairman of International Excellence Federation for Bariatric and Metabolic Surgery. To his honor, he was the first to publish single incision transumbilical laparoscopic Roux-en-Y gastric bypass in 2008. He was the first to do laparoscopic adjustable gastric banded plication in the world in 2009. In 2011, he was again the first to do laparoscopic DJ bypass with sleeve gastrectomy. He started first international center and he was awarded first surgeon of excellence for bariatric surgery in Asia Pacific region in 2009. He was Congress President for IPSO-APC 2013. And I'm happy to remember that not only Professor Huang gave keynote addresses in Ahmedabad, but he also performed a live surgery in 2012. He has published books on advanced bariatric metabolic surgery and also essentials and controversies in bariatric surgery. He has also published 4 more books in Chinese and Taiwanese language. He is on the editorial board of scientific journal in Tech. He is also on the editorial board of Asia Journal of Surgery and also on the editorial board of Surgical Techniques Development. To his credit, he has immense interest in laparoscopic bariatric and metabolic surgery and also single incision transumbilical laparoscopic surgeries. Friends, he is very academic and has published more than 100 papers in internationally renowned journals. Majority of them I could see are in the field of bariatric and metabolic surgery. We are very happy to have Professor Huang here on IAGES Prime Time. And Dr. Huang, you are most welcome to IAGES. And I am sure our interaction is going to go for a long way and we'll keep inviting you again and again for the exchange of academics. Thank you for accepting our invitation and being here tonight. I will now invite Dr. Kanagwal to take this program further. Thank you.
Thank you, Mr. President. It's been a lot of sharing experience and our relationship with IAGES and Professor Huang. And it is a very proud moment to have after a gap of 9 years in yet another program of the IAGES. I warmly welcome Professor Huang. I have the pleasant duty of welcoming our own mentor, philosopher, and the immediate past president of the Indian Association of Gastrointestinal Endoscopic Surgeons, Dr. Raman Goyal. During his presidency, the corona struck once he took over the presidency, so not many activities could be done on physical mode. But then at that time only IAGES started experimenting the virtual mode, and I think the last 1.5 years this IAGES is turning a truly virtual academy, and I hope, as President said, we'll have more physical programs. Ladies and gentlemen, Dr. Raman Goyal is an eminent weight loss and bariatric surgeon. He is the director of the bariatric and weight loss program at the Okat Hospital, Mumbai. I am in fact happy to share that he migrated into a single specialty of bariatrics very early into her career, quitting all the other advanced laparoscopy and basic laparoscopy. Right now, he is the editor for bariatric surgery in various journals, and especially they have created a new journal on behalf of the Obesity Surgery Society of India. And he is also taking care of the JMAS, our official journal of the Indian Association of Gastrointestinal Endoscopic Surgeons. Apart from that, he also is the official board member for the Super Specialty Board of Bariatrics for the National Board of Examinations in Medical Sciences, New Delhi. He is the chairman, scientific committee for the World Congress of Endoscopic Surgeons. It's a federation of the Global Society of Endoscopic Surgeons, which is going to happen in Kolkata in the coming couple of years. Dr. Raman Goyal has been instrumental in creating various activities on exclusive bariatric surgery, especially the IMMAST, the board which teaches the young surgeons into the specialty of bariatric surgery. With that few words, may I have the honor of inviting Dr. Raman Goyal to call the session in order and conduct the program. Over to you, Dr. Raman, sir.
Thank you, Dr. Popat, President IAGES, and Dr. Raman Goyal, moderator for this program. I think it's like homecoming when I come back to IAGES Prime, and also when I interact with Professor C.K. Huang. You know, it's a very rare honor that I have chaired or moderated more than 5 to 6 sessions of his. I moderated his live surgery. I was in US and he was demonstrating from Taiwan on behalf of ASMBS. And I have done it many times in India. And it's a real pleasure because he's primarily a teacher who has groomed so many surgeons in India and in other countries. And that is the strength of Professor C.K. Huang, whom everybody calls C.K. So I'll stick to C.K. And C.K. has a lot of, besides the pioneering work, he has a lot of original thoughts and ideas which he has implemented in developing new procedures, and which interests surgeons across the world. So without wasting much time now, I'll invite C.K. to take his talk today, and then we will have questions. And I know so many people are watching your talk. We will have a lot of discussion at the end of your talk. So please welcome once again. Please go ahead. Can't hear you.
You can hear me?
Yes, now better.
Okay. Thanks for the invitation. The first thing I want to thank IAGES that I have joined your program since almost 10 years ago. And go back to the president of IAGES and also the past president of the Raman Goyal. Today I'm going to share my experience about the weight loss surgeries, about the managing the complication and challenge. So I hope that you can enjoy this about 40 minutes for the presentation. So hope that we can continue the education programs for a long time, as long as I'm still doing bariatric surgery. Thanks for the moderating from my best friends, Raman Goyal, that we have known each other for many years. First, I want to talk about the challenge. Surgery right now, in fact, is the most effective and long-term solution for morbid obese patients. In fact, in Asia, we have done this more than 20 years. For the whole world, in fact, it has procedures for more 1 million. So the results have been very long-term results, more than 20 years, and also a lot of people get these procedures. So in fact, from the beginning till now, we have run a long time for this. I want to share first is about the Taiwan bariatric surgical and treatment volume, including bariatric endoscope, like the balloon or Botox and ESG. For these 10 years in Taiwan, we have set a registration very similar to the OC society. Since 2010, the volume is about 1,000 cases. And since 2014, the volume increased to about 3,000 cases. So you can see very soon we reach the plateau. And Taiwan's population is about 23 million. The very lucky that last year for the COVID-19 conditions, we did not drop in the volumes. We still proceed the same volumes. The females is the main predominant to receive the procedures, about 60%. The males about another 30%. You can see, according to the distribution of the volumes, we have very diverse and different procedures. But if we look at the procedure now, number one is about the Ruai bypass. So in the first 10 years, since 2010, the volumes gantry bypass is the major one, Ruai bypass. But it's decreasing a lot. Now it accounts about 100 and more. So it dropped a lot now. The second is sleeve gastrectomy. The sleeve is going up since 300 cases. Now it's going to about 2,000 cases. Another thing is mini gantry bypass. 3 years is more than the Ruai gantry. And there's also some the other procedures. Sleeve with duodenal jejunal bypass or sleeve with proximal jejunal. It counts some proportion of these procedures. And gantry bending procedures, in the beginning, there's some cases, but eventually now almost disappear in our society. Revisional procedures now is accounted about 5% in total cases. Okay, this is the condition of Taiwan surgical volume plus bariatric endoscope. According to the distribution of the patient, the BMI is around 35 to 40 in the average. The age is about 40 years old. Recent a few years, you can see the age is increasing in average. I think it's because we start to do metabolic surgery now. Very good quality of the Taiwan surgeons in doing bariatric surgeries. Since beginning till now, the mortality rate is always less than 1%. You can see it's almost about 0.1% in average. And for the readmission and reoperation rates, it also was kept very low. So the surgical condition and surgical quality of life, in fact, is quite good comparing those the other countries' conditions. And in Taiwan, the registered centers in the first 10 years is increasing a lot. But recent 5 years, it's almost about 30 centers. And very interesting is the high volume center, more than 200 cases a year, is about 4 to 5 centers. There's not much change for these 5 years. So the important notes for the challenge, I think sleeve gastrectomy has become the main operation since 2014. Then now it's going up to about 55%. But the surgical volume cannot be increased, and have very unlucky that we see it reach the plateaus. Even we have very low mortality and reoperation rates in our society some way. The numbers of high volume centers is very stationary. there's not much increase. The second is I want to share my experience about our centers. So I started this service since 15 years ago. So the first year, only 9 cases. Since that time, we increased a lot. Right now, every year, we have about 400 cases a year. And you will see in 2016, there's some dropping. It's because that time I changed the hospital, the shift from Kaohsiung to Taichung City. So there's some dropping in that year. Expect, okay? So you also, what is the main procedure for us? This is blue eye bypass in the blue bar. The blue bar increased till about the 20 and 10. Then stop to dropping. And sleep gastrectomy, we start from 20 and 7. Up till now, it still increased a lot. And another procedure is sleep plus, including the sleep with duodenal jejunal bypass and sleep with proximal jejunal bypass. Now it accounts about 30% of our total volumes. And revisional surgeries is always stationary. I have case of my own self and also have the case from referral. So it's about 2 of third is referral, 1 of third is from my own patients. So the 10% is about for revision. So in this condition that you will see, we incorporate sleep with plus the jejunal bypass. This is sleep with jejunal bypass and also sleep with proximal jejunal bypass. This is the main 2 procedures that we are doing in our centers. So here I'm going to share to you about how we do the sleep with duodenal jejunal bypass. I hope that you can see the video very well. We routinely do sleep with DJB as a purely metabolic surgery. So we would do sleep with conventional methods, dividing the greater curvature vessels and to the angle of peace, and divide it till the EC junction, and going down to the pyros, and then we remove junction. After marking the resection knife 4 centimeters from the pyros, and then we can start to do the transection of the stomach. It's a French 38 Fuji. The marking is very important because it can make the cutting lines very straight without the zigzag transection to prevent the torsion. All the crotch must be removed during your transection. After sleep, we do a suspension to hold the stomach, then going to transect the duodenum with cautery and dissection. We use dissection, then passing through the retroduodenum tunnel with the Goldfinger's vector. Then we can put the suspension tab going through the tunnel to hold the. Then we can start to do the transection with curved tip tri-staple. Okay, so when we passing through this stapler, we remove the suspension tab. This is between the first and second duodenum junction. Okay, after that, for homeostasis, then we're going down to the jejunum. I pass about 2 to 3 jejunum according to the patient's BMI and also the C-peptide function. Then we do a suspension sutures to meter in and jejunum. Then we can do side-to-side anastomosis. We use the 3O Prio to do 1 layer total anastomosis, jejunal anastomosis. This technique, you can do 2 layers, of course. For my routine, I just do 1 layer continuous sutures. Finishing the posterior one, then we can go up to the anterior with continuous sutures. Then you can, after finishing this procedure, do a leak test or using pendoscope to see the anastomosis, to see any bleeding, any insufficiency, or checking the safety. Then we these suspension sutures for the anastomosis, this posterior and also anterior is perfect. Then we check out the sutures under traction, and then we do torsion suture on the jejunum and antrum to prevent the efferent loop syndromes. Then we have to cross the Peterson defects. Then the procedure was finished. Okay. Then we can put the 1 drain. Before that, we will fix our sleeve gastric tube. The stomach tube is now sleeve gastric tube. Okay. Then take out the liver suspension tabs. Then put a drain, retro duodenum space, and going up to the east is the drain. This is the only left drain. This is sleeve with duodenal jejunal bypass. Okay, so the second sleeve plus procedure I want to share with you is about sleeve with proximal jejunal bypass. This procedure I use mainly in super obesity patients, for those BMI more than 45. The port still the same as a sleeve gastrectomy. We put as a 4 ports. Then we do the liver suspension tabs. Then do devascularization of the greater curvature as the conventional sleeve gastrectomy. The sleeve with BJB and the conventional sleeve. After this sleeve, we would direct the fix to retroperitoneum. This is when we finish the sleeve. Then we're going down to the counting the small bowel. Okay, this is triceps ligament. Then we our 20 centimeter from the triceps ligament. Then we use the white staple to cut proximally. Okay, this is the proximal parts, the 20 centimeter. Then we're going down to bypass the jejunum 3 meters. So we can start to counting. Then we bypass 3 meters. You will see this much easier than the duodenal jejunal bypass without cutting the duodenum. So then we can repair the stoma with the total hands-on sutures. I always routinely use the 3O mono. Then after crossing this with the hands-on suture, then we need to cross mesenteric defect at the end. Okay, so that the assistant to hold suspension sutures. Then this is the intermesenteric defect between the jejunum and jejunum. So after this, we can finish the operation. This is a sleeve with proximal jejunum. for our centers, I think I have one important note. Number one is post-gastric bending and root-wide bypass are decreasing in recent 10 years in our center. Even we are the first center to do band with plication. Number two, sleeve gastrectomy has become the main operation since 2012 and now going up to about 50%. Sleep plus is gaining acceptable in our center, up to 35% of the volumes. Revisional surgery in need is about 10%. Even though we have started this procedure for 16 years, but when you see a lot of randomized trials that are showing to the population and also the endocrinologist, the surgery is much better in the weight loss control compared with the medical treatment. And this data surgery versus non-surgical treatment for type 2 diabetes is many advantage to see it from the bariatric surgeries. Can get a very good remission results, but we still cannot persuade a lot of endocrinologists to help us for treating the patients by recent 3 to 4 years, Taiwan, we also have GLP-1 medications. And semaglutide has been starting for the trial. You will see after 52 weeks treatment by the GLP-1 medications, injection weekly, it can achieve 16.2% weight loss. So this another issue is the other ES in our center. In this, we also starting ESG. The patient seems to be able to accept this concept by endoscopic treatment, but not by cutting the stomach. According to the 5-year results, that has been can achieve about 15.9% mean total weight loss. And about 61% patient can maintain more than 10% total weight loss in this morbid obesity group. So it seems to another solution and also one choice for the patient in the future. So the challenge is, I think surgical procedures evolve very quick. In this 16 years, we see some procedure coming up, some procedure disappear. So surgeons always face the new learning curve. Not only the young surgeons, but also the senior surgeon like me. I have done so many procedures, more than 6,000 cases in these 15 years, but we still learning the new procedures. And still very rare referral from the physician. It's unlucky that we did not see the physician really accept these procedures. They still did not help the patient to select the surgery for them. Then is the new modality and medication was get involved in obesity treatment and also attract the peoples. Number 5 is the complication of surgery, still always the main obstacle of the acceptance. You will see very few procedures can achieve less than 10% complication overall. I think that is the main problem that to persuade all the patients to receive the surgeries. Second is, I want to talk about the complications. I think for most senior bariatric surgeons, you can understand that we think bariatric surgery is treating the life and also the medical issues. But most of the patients think bariatric surgery is a cosmetic surgeries. So when there's complication happen, they thought it might be medical areas. When we're talking about this, I want to talk about the history of bariatric surgery first, to see what happened in recent 40 years in bariatric surgeries. I think very few surgeons knows that what is the first bariatric surgeries. in the history reports, in Spain, this first bariatric surgery was proved, the king of Leon. Then that times, because he is morbid obese, so he cannot walk, and his grandmother do a procedure, transfer him to another doctor to have a surgery. Then he can lose weight. He suture the king's lips, make the kings cannot eat but only drink through a straw. So he start to lose weight. But why we did not do it? It's very simple. We don't need to cut the stomach because the quality of life is very bad by these procedures. So in fact, even this is the first operation, but right now we cannot see it anymore. Another evidence-based bariatric surgery in the history is jejunal ileal bypass. But the problem of jejunal ileal bypass is a lot of complication from metabolic events, and also the quality of life is very bad, like diarrhea, vitamin deficiency, and the kidney stones and the liver failure. So right now, there's no any surgeon doing this procedure anymore. This is the duodenal switch, accounts about less than 5% in the world for all bariatric procedures. In Asia, very few surgeons do these procedures. Why not accept it? Because of malnutrition. I'm not sure whether Raman Goyal you ever see this procedure. It's called the vertical bended gastroplasty. In fact, there's no malnutrition issues, but we abandoned it because the very high weight regain rates and very poor eating quality of life. The patient experience very often vomitings, and the patient's weight loss is not good enough. This is the gastric plication. If some surgeons still remember, about 70 years ago, then gastric plication suddenly coming up in the Asia area. It was invented by Dr. Talabo in Iran. But right now, almost nobody do it anymore, even without suturing, without cutting, because of weight regain from the gastric plication. In some cases, in fact, did not get sufficient weight loss. So in this procedure, without the hormone change, then the patients will not get the long-term benefits. This procedure, in fact, in my opinion, is very similar to ESG. I don't think the ESG really long-term can get the really long-term results, maintaining the weight. Gastric bending starting from 1919 and has been occupying the first 20 years in bariatric history, but the weight loss long-term seems not very good, and there's some revisional rates. But the good thing is that it is very safe without cutting the stomach. So in 2009, we started to do the band with plication. We also published the midterm results, but unfortunately, the company withdrew the gastric band in Taiwan now, so we don't have gastric band to be used anymore. The problem of bending procedure is very good compliance is needed, but very high failure rates, about 30%. The revisional rates for long term is also achieved about 30%. The less weight loss and comorbidity resolution was also observed in the gastric bending procedures. So when these bariatric procedures get abandoned, I think there's 5 reasons. Number 1 is if the weight loss results cannot achieve 50%, we call failure. The second is after these procedures, the patient get very poor quality of eating or poor quality of life, no matter it's a malnutrition issue or because of eating problems. Number 3 is low remission rate of comorbidity, especially for diabetes, hyperlipidemia, hypertension. Mostly is related to the weight loss is lower. Number 4 is when the patient have higher complication rates in that procedures, like the duodenal switch, the long-term malnutrition issue, like jejunal ileal bypass. Number 5 is difficult surgeries. So when the surgery is difficult, when you want to make it more expanding in the volume in the world is also become difficult. So you will imagine that why sleep gastrectomy can get very soon expansion in the world and get very good percentage, because the weight loss in the 5 years more than 50%. The quality of eating and life is good. The remission rate of diabetes is still very high, more than 60%. The complication rate is acceptable, less than 10%. The surgery is easy. So looking at the root-wide bypass, the gold standard procedures, we saw in the beginning, in my first bariatric practice, there's only gastric bypass. So I do a lot of gastric bypass in my history, and the remission is good. The weight loss is good. There's a good hormone change. It can remit the GERD, and it's reversibility, reversible procedures. So that time, I think this is very good procedures. But unfortunately, when I do it very long times, then we found that the patient has some problem in our Taiwanese patient. 20% marginal ulcer, 15% have the dumping syndromes, including the anemia issues, iron deficiency, and some vitamin deficiency. The patient needs a very high dose of vitamins. And for gas passage, long-term have osteoporosis. In Japan and Korea, there's remnant stomach concern because of high prevalence of gastric cancer. So this is a disadvantage of these procedures. So sleep gastrectomy has become the #1 procedure in the world. When you do a good procedures for sleep, the patient can achieve satisfactory results and also acceptable remission of diabetes. So in our center, we found the sleep complication achieve around 10%, but we will see some patients from the reflux, some is from the weight regain issues. For the leak and strictures, in fact, it's very, very low, less than 1%. So the surgical complication for the first immediately post-operative is very low. So I think it's safe and also quick procedures. So I want to talk the challenging and complication in the sleep gastrectomy. #1 is about reflux. It has been discussed in many society meetings. I would say the reflux issues in GERD has been some reports. And in fact, in very early in 2012, we have published the first series about the reflux issues. We found after sleep 1 year, the patient have increased GERD symptoms and also the prevalence. So we will see when the patient after the sleep, those who before surgery without the reflux, after surgery we develop more reflux, and from the GERD A more to the GERD B and GERD C. Okay, and you will see very interesting that increased the hiatal hernia percentage from 6.1% to become 27.3%. We found the patient is male one and post-operative. There is a new hiatal hernia. The patient will develop more reflux. So this meta-analysis also include our study. This 10 study included 600 cases more. The prevalence of Barrett's esophagitis after sleep is about more than 10%. And very interesting that the risk of esophagitis increased every year more than 13%. So the prevalence of Barrett's esophagitis loss after sleep seems to be high. And most of the cases was observed that developed the Barrett's esophagitis after 3 years. So when you follow up the patient long terms, you will see more Barrett's. And also the reflux issue is also another concern. So when the patient develops reflux with your PPI, you can try the balloon dilatation. And if the patient have new hiatal hernia, you can do the hiatal hernia repair, take down the migrated gastric tube. And sometimes we have to revise to the root-wide bypass. In those with hiatal hernia more than 5 centimeters or Barrett's esophagitis, and when you see the sphincter incompetence. So this is the video that we publish in the obesity surgeries for those who have intractable reflux issues. The patient have sleep 3 years ago. Then after that, the patient start to experience reflux and hiatal hernia. So this is what we do for the patients. We found the patient have introsoracing migration. So this is the video. We see the sleep tube. The sleep tube was not dilated. Looks very good in the gastric volume. We have to open the adhesion. Then when you go to dissect the EC junctions, in the beginning, we saw, okay, there's no problems. But when we open the height, it's very big hiatal hernia. So we have to open everything, then take down. See, this is area of the staple, the last staple. So in fact, the tube was migrated to the mediastinum. So we open the laser sac, the right cruise, and the right cruise and left cruise. You will see this is the defect. The defect is almost about 4 centimeters in the diameter. So this is left cruise, this is right cruise. Okay. With the H-bone non-absorbable sutures. You can do horizontal to prevent the muscle disruption. So we close the hiatus tightly. After this, you can see we have the intra-abdominal portion of esophagus. After this, we are going to ligament tears to wrapping the EC junction to create the adhesion tears and gastric tube and also the cruise. So wrapping this and also the end of the gastric tube to the ligamental tears and then to the cruise muscles. Then and cut the gastric tube and ligaments, we do sutures. Okay, so this is the way that we prevent the tube migrate again. We fix back the gastric tube properly that routinely we have done for the sleep gastric tube. Okay. In fact, this method has been described by another surgeon. So we routinely, during the primary procedures, we are going to fix the gastric tube to prevent motion. So if the patient have hiatal hernia in endoscope, then routinely dissect the hiatus, and then after this, we would suture the gastric tube, the end of the staple, to prevent the future migration tube to have the reflux. Okay, this is now our routine to prevent. But we don't have published the data, but we see the reflux issues decrease a lot after this. Another difficult complication is about the leak. I think for worry about the sleep leak and very difficult to manage. And unfortunately, most is happen in proximal third. Most about 70% it can happen in the proximal third. So the best treatment is to prevent the leak. The first is prevent the Z-shaped gastric tube, and some surgeons routinely oversaw or implication a staple line for the upper third. And don't go too close to the G junction. Do not cut the esophagus. And in the laser curvature vessels, especially depth the gastric artery, you have to prevent the devascularization. And also fix the gastric tube to the retroperitoneum to prevent the torsion and narrowing sutura. I think everybody knows how to treat the leak. But in fact, for the leak, when it happens, there's a lot of surgical methods to manage that, including conservative treatment, primary repair to the tissue, or do the total gastrectomy for that cases. Of course, stenting is the first primary procedure that when you encounter the problems. The result of leak, if you did not make it healing in the first stage, then it can become chronic leak, even become the fistula. Can be enterocutaneous fistula, gastrobronchial fistula, or enteroenteric fistulas. And it also can cause a long-term malnutrition and mortality. So here I want to show you that some surgeon, when he face the chronic fistulas, how he manages that. I think this is a good procedure that to remind the surgeon that it could be a final solution for chronic leak or loss with fistula. I want to show you the video. This is a case after sleep, but developed leak. The 29 years old, there's chronic gout on the NSAID. He underwent sleep. After 6 months, the patient suddenly have the hematochezia, then sudden abdominal pain, come to the emergency room. The BMI from 41 dropped to 28. During the emergency room, the endoscope see there is some pus in the EC junction area, and in the antrum part there is bleeding vessels. So he do the hemoclip. Then in emergency room, during the CT scan, you will see that very interesting that there is a very small air bubble near the EC junction, and that the endoscopic paste. So during the CT scan, when we carefully to look at for that, you see the air bubble is over there. GI series, we found there is a small leak from the EC junction, but it has been 6 months after surgery. When we're doing the laparoscopic exploration for this case, we found the patient have 2 leak sites. One is in the antrum, another is near the EC junction. This is very rare case that I never seen that there are 2 leak sites. Okay, so we found this is the leak. When we're going up to the EC junction, we use the dissector with us abscess from the EC junction. So we have to consider how to do the operation for this case. And then the pain is very bad. The staple line is here. We found beside the staple line. So it looks not from staple line. It might be a new gastric arch because of the patient take an NSAID. So we decide to resect the middle part of the stomach, the lower part antrum. Then we open the ulcer perforation part. It's very close to the EC junction. This is the second perforation in the antrum. So we resect this, take it out. Now we have one small gastric pouch, and then a lateral part of the hole. Roux-en-Y for the Roux-en-Y bypass. Then how to do anastomosis? We have to do the total hands-on. This is the branch 38 G-tube, then you will see the stomach tissue looks not good because of chronic ulcer, but the small confusion, everything is good. So it's the jejunum flap to suture to the perforation site, become a lateral gastrojejunal anastomosis. Then we cross the mesenteric defect, cross the pleasant defect, and put a drain in this case. The case recovered very well. We lost. Okay, so my conclusion for my presentation, I think after nearly 60 years development of weight loss surgeries, I think it is still evolving according to the new concept of mechanism that we found in science in obesity and GI hormones. Challenge is still in many aspects because there is still no single standard. I think that for the main challenge is that the endocrinologists and the general population do not accept it way. So why do we still need the time to fix it? The reflux and leak are the most common complication in sleep gastrectomy. In fact, in the beginning, we saw that it's an easier procedure without creating any malnutrition. But how to manage these difficult complications still one of important missions for us, right? My final opinion is that we have to keep learning from the patients and all the mentors. I think this is what our teachers and mentors teach us, that the patients are always our book, especially in bariatric surgery field. This is very new for most surgeons. And even in some countries, there's still no fellowship programs. So I think to learn is the Bible for all of us. So in the end, I still want to thank the support from Indian surgeons that I personally have trained more than 80 surgeons from India. So I'm very familiar with Indian society and also the Indian culture. I love Indian food too. In these 2 years, I cannot travel to India because of COVID. Hope the COVID go off, then I can travel to India, one of my favorite countries again. Thank you so much.
Thank you. Thank you so much, CK, for such a wonderful presentation. There was some audio disturbance, but you made it up with such beautiful videos and which were so self-explanatory. Of course, the president is here and we would love to have you soon in India and to compensate for the 2 years that were lost to COVID. And I think you have very well raised the questions of challenges in bariatric surgery and also spoken about prevention in between. And some of the things that most of the senior surgeons do experience and probably learn from their patients. And yes, we started with vertical banded gastroplasty in India. So from 2000 to 2004, we were doing those only till the bands got introduced. And it was a challenging surgery because we were doing them as open surgeries those days. And later on, the laparoscopy started somewhere about 2001, but we started doing bands laparoscopically. So coming back to your topic, I have a few questions before I take up the questions that are pouring in from different surgeons. So the easiest question to ask is, how do you select a procedure for a patient? I mean, is there an algorithm? Is it your hunch towards a patient? Because there are no guidelines, no national guidelines or international guidelines on selection of a procedure. And that, I believe, is the biggest challenge that bariatric surgeons face.
About the selection of the procedures, I think in every different hands of surgeons, they have different option for them. When you have more modality in your hands, then I think you can offer more service for them. So right now, in Taiwan, some surgeons, they only do sleep and UI bypass. Some surgeons only do sleep and MGV. Some only do sleep. So sleep cannot fix everything. When we see more patients, like if the patient is high BMI case, especially the super obesity, if you do only sleep care treatment for the patient long-term cannot get good weight loss. So in Taiwan, most of the patients cannot accept the two-stage operation concept. They want a one-stage fix all the things. So in those super obesity, we would offer intestinal bypass at the same time. So might consider UI bypass or consider the proximal jejunal bypass or consider duodenal jejunal bypass. We select the patient according to the patient have reflux or not, the patient have the diabetes or not, the patient have any issue, contraindication for the sleep treatment or not. Or those who the patients worry about remnant stomach issues, or those who have the chronic atrophic gastritis, might be a precursor of gastric cancer, we will avoid the UI bypass. So there's a few criteria, including the diabetes condition, including the BMI, including the GI condition of the patients. This is the most three conditions that we would take into account whether which procedure is suitable for patients. So I think mostly simply to say is that for those who super obesity, we would love to do sleep plus procedures. Then if the patient have severe reflux or in contraindication for sleep, we will consider UI bypass. For low BMI, purely metabolic surgeries, we would do sleep with duodenal jejunal bypass or UI gastric bypass for the patient. That is the main selection for our patient.
Yeah. Okay. And one of the things that you showed so beautifully is the cardiopexy. And you said you are using it as a preventive procedure, and besides doing it in revisional cases. So what are your outcomes? I know you said they are not published yet for the primary procedure, but what are your outcomes, if you can share some detail about? So patients who already had, let's say, a hiatal hernia reflux disease before the primary surgery, and you did a cardiopexy, does it reduce the possibility of post-operative reflux, or is it as good as a Nissen sleeve? So what is your take on that?
Okay, personally, I do a few Nissen sleeve, but only those who is not high BMI cases without diabetes, those like BMI less than 35, maybe 27 to 30, the patient have some metabolic comorbidity. The patient coming to us because of severe reflux, then I would suggest the patient to have Nissen sleeve. But mostly for those who have severe reflux, girls see more, or those who preoperative have barrettes, I routinely do UI bypass. That I suggestion to the patient. But if the reflux girl A or B, the patient have hiatal hernia, we still do sleep-based procedures like sleep BJV or sleep alone. Then during the pre-op pendoscope, if the pendoscope showing this hiatal hernia, we routinely do dissection of hiatal hernia, we repair it. If the patient before surgery there is no hiatal hernia, but during the operation we found the patient have hiatal hernia, we still dissect it and close it very tight. Then before we did not routinely do cardiopexy because that time we did not know the concept of introsoracing migration. The introsoracing migration is coming from the loosening of hiatal muscles. But before, most of the patients don't have the issues. Why it happens? I found that it's mainly from the patient losing more weight. The patient's muscle become weaker, especially those female, those who did not do exercise after surgeries. So when you go in to do the hiatal hernia dissection, you see very weak muscles. I think that is the main reason So we have the data showing the patient lose more weight, the percentage of weight, the new hiatal hernia can happen. So in fact, it's a new hiatal hernia. It's not a preoperative days hiatal hernia. So in this kind of case, if you want to prevent, what do we do right now? We do cardiopexy to prevent the migration, but we cannot prevent the weakness of the muscle. So for those who are high BMI more than 40 cases, especially without exercise, without a gym training habit cases, we will encourage the patient if the surgery need to suffer enough proteins, do more exercise to prevent the migration issues. It means that the muscle weakens. Right now, we routinely do cardiopexy for these 3 years. We see a lot of decreasing in the new reflux issues. But the patient might still have mild reflux, but we did not see severe reflux. So right now, we see the revisional rates dropping a lot for the reflux issues. We need a more long-term result, but I think every surgeon doing sleep, you have to do the cardiopexy for your patient, because when we finish the sleep tube become very slim. It even is the same diameter as the esophagus. So for the migration, it's very easy. Even without the weakness of hiatus muscle, it still can migrate up. When it happens, then the reflux is accompanying with the patient always.
Okay. Sunil, do you want to ask a question about this cardiopexy, because you do so many fundoplications? How strong this is as a anti-reflux procedure?
Yeah, thank you, CK, for excellent lecture and videos. Very nicely done. I was just going to ask regarding cardiopexy. We are doing quite a lot of fundoplications and hiatal hernia repairs. Mainly, we are not doing this ligamentum teres cardiopexy. In bariatric patients, in redos, I think it is very helpful. And what is your take on anterior gastropexy and revision hiatal hernias, apart from bariatric surgery? Without bariatric surgery, if you are operating on a revision hiatal hernia, or you don't do anything but bariatrics. Did you get the question, CK?
You mean the Nissan fundoplication myself?
Yeah, I mean, if you are not doing bariatric surgery and you get only a revision hiatal hernia, would you be routinely using cardiopexy?
You mean not the bariatric patient? Then I face the reflux issues. Okay. In fact, because I'm upper GI surgeon, so in fact I still see some reflux patients come to me. So if the patient is not obese, then mostly I just only do Nissan fundoplication. But for those who we do Nissan fundoplication and hiatal hernia repair, I don't do cardiopexy because the stomach size is big. Then there's wrapping 36 degrees wrapping of the fundus. So in fact, it would prevent the migration of it. So only in sleep gastrectomy case, we do the cardiopexy. In primary procedure of anti-reflux.
Right.
Yeah.
Chika, I was very curious to ask about, your malnutrition in when you do a 300 centimeter of jejunal bypass.
The duodenum jejunal bypass and the proximal jejunal bypass. In fact, these two procedures, I think, is totally different procedures. Because in Roux bypass and duodenal jejunal bypass, we bypass the duodenum and also the proximal jejunum. In fact, Roux bypass, we bypass about the 90% stomach. In sleep-based procedures, we preserve about 100 mil the gastric pouch. So the stomach is much bigger than the right gastric bypass, only 30 cc. But both of them bypass duodenum and proximal jejunum. So we see more vitamin deficiency problems from the procedures. But sleep with proximal jejunal bypass, till now, I have done more than about 1,500 cases. There's no any case need a revision because of malnutrition. The patient will not experience the false smell of the gas or the severe diarrhea issues, and all those with malnutrition from the vitamin deficiency. And even the iron deficiency or the other vitamin deficiency is very similar to sleep alone. So I think we did not bypass duodenum helps a lot in absorption of the nutrition and minerals in the proximal jejunal bypass. Very honestly to say, I think a lot of Asian surgeons all in the world, very few surgeons start to accept these procedures. But I would say in the future, this procedure might become the most predominant procedures in the world. Because personally, I have done a lot of revisional surgery from the other surgeon's hand. So no matter it's root-wide bypass or sleeve with duodenal jejunal bypass or MGB, in fact, right now the revisional rates looks lowest in the sleeve with PJB, with proximal jejunal bypass, and we did not encounter malnutrition issues, and the weight regain issue seems also very low, even seems compared with root-wide bypass. So let's see. I think it still takes time to prove.
Do you reserve these procedures for super obese, or you can offer to anybody?
In Taiwan case, I routinely for BMI more than 45. 45, I think this is Asia super obesity. So we recommend sleep plus jejunal bypass. And in the BMI lower than 45, in poorly controlled diabetes, then C-peptide functions less than 3, then I routinely do the sleep proximal jejunal bypass. This procedure achieve in this kind of criteria in diabetic remission, they can achieve 90% remission rate. But if the patient's pancreas function even lower, C-peptide fasting 1 can less than 2, and the diabetes duration more than 5 years, I recommend the patient to have the sleep with duodenal jejunal bypass. I think bypass duodenum still help for foregut exclusion, helping in the diabetes remission. So we still have some selection criteria for diabetes and also for both different bypassing small bowel.
Okay. What about vegetarian patients?
In Taiwan, very few vegetarian patients, so we did not take into account. Till now, I've done 6,000 cases. I think less than 20 cases are fully vegetarian. So I think it's not a big problem for us. But in these vegetarian cases, as I remember, most is only sleep gastritis. So, but I know that Asia, in India, you have a large population. So protein supplement for vegetarian is a very important issue. But very luckily right now, we have a lot of protein powder for vegetarian. So I think they can support the protein powders without limitation. I think that maybe can help the patient get remission of disease, good weight loss, but no protein insufficiency problems.
Thanks. Raman?
Yeah. So, CK, just last 1 or 2 questions for you. You said you had a trial of semaglutide in Taiwan as well. There's a lot of excitement among physicians because 15 to 20% total weight loss is as good, as close to surgical results as. So, do you think that this will replace the bands and the balloons and ESGs in times to come? Semaglutide.
Okay. GLP-1 now, there's a lot of products, including Trulicity, semaglutide. Right now, they can use from the daily use, right now become weekly use. I heard that pharmacy company, they are going to monthly use. So it's a new invention for mostly physicians, surgeons need to face. Frankly speaking, I have starting to use GLP-1 almost 1 year in our practice. Not only in bariatric surgery patient, I also to treat those with not the morbid obesity or like stage 1 obesity, class 2 obesity, they have some comorbidity. In Taiwan FDA also approved the GLP-1 as an obesity treatment for BMI more than 27 with comorbidity. So when you use the medication to treat them, you will see the result is really good. The patient decrease the hunger, very good the satiety. The patient, when you give the education program, including the diet changing, the patient can achieve, in fact, more than 10% weight loss. They can even achieve about 20%. So we use in medical treatment group, those who cannot accept surgeries in morbid obese patients, we will try to give them. Number 3 is super obese plan for surgeries. If the patient have very bad cardiovascular and respiratory functions, then we'll give the GLP-1 for 2 weeks or even 1 month before surgery. The patient can lose about 10 kilos with this. Then we can do surgery easier. Number 4 is we use GLP-1 for those who have weight regain after bariatric surgery, especially sleep gastrectomy alone. Because we found the sleep gastrectomy has higher weight regain issues after 2 years. When you adding the GLP-1 to the patient can achieve another 10% weight loss after you give him GLP-1. So I think this medication, as a surgeon, we should incorporate this into our practice. But very interesting is that the medication is very similar to previous medication, like sibutramine. Then, in fact, the results in morbid obesity or super obesity, after 1 or 2 months treatment, it will stop. It is not the same as the low BMI case can achieve so good weight loss results. So I think surgery is still much better compared with the GLP-1 analogs medications right now. But the pharmacy company is going to invent GLP-1 plus GIP. Then I think would be start to go into the market next year in USA. So I heard that the weight loss result can achieve 20%. So I think as a bariatric surgeon, I also told my fellows that not only do surgery. In another hand, you must having the ability to use medication to treat all your patients. I think this is the future trend. We don't have choice. But the money cost in GLP-1 is much, much lower compared with using the balloon or ESG. ESG is truly expensive. In Taiwan right now, it costs $10,000 for the cases. So it's very expensive.
Yeah. So we are also using the liraglutide in India, and we are expecting that semaglutide will come in oral form also within a short time in India. So looking forward to that. So the last thing is, so many of your fellows who have gone from India, they all worship you. You are like a cult leader for them. They swear by you. They will not tolerate anything that's spoken about you. What is your message to young surgeons, young bariatric surgeons from India and other countries who want to take up bariatric surgery? What would be your message? Who want to do only bariatric surgery? Is it worth doing, dedicating a life to bariatric surgery, or one should retain general surgery as part of their work?
I think my message is always changing every year, because even the bariatric surgery evolved very quick. we don't know what is the next 5 years, 10 years. But I always, before their graduation from my centers, I always give them very important message that right now what you learn from CK is always wrong. When I give them this message, they always very weird face. I tell them that what you learn from me, in fact, is just one step. So maybe the medicine change, or someday the new surgery coming up. And I also learn a lot of new mechanism from obesity. So right now you learn, maybe next year is different, or maybe it's wrong. So you have to keep flexible. For young surgeons, I think you must take yourself as a GI surgeon's concept. The obesity treatment is not cosmetic surgery. We are changing the GI tract. I told the patient, we cannot change your gene, but we can change your gene presentation. It's your GI tract. So when we change your GI tract, we change your hormones, then your behavior change. So remember one thing, you are GI surgeons, so you can treat reflux, you can treat gastric cancer, you can treat obesity because of it coming from the GI tract malfunction and the hormone imbalance. So if you have the concept, I think your field is very wide. I start as a general surgeon. In the first 5 years, I do a lot of general surgery works. Right now, I most get immersed only bariatric surgery because I have very high volumes. So I don't have time to spend the other parts. But if you are a young surgeon, try to immerse yourself in every aspect, because every learning helps you in all aspects of the surgery. Especially in bariatric patient, I think you need to learn emergency surgery concept, how to treat the patients when the patient is on critical conditions. So if you only learn bariatric surgery, you might put yourself to be on the risk of the crisis when you face very difficult patients. So keep learning. I think that is my final word.
So well said. Thank you so much, CK, for such a wonderful talk. May I request Dr. Kanagvel to take over from here, please?
I would like to ask one question, CK. Excellent lecture, and you covered everything. I would like your opinion on ESG. Is it not the plication from inside? And how do you compare it with the gastric plication we used to do before 10, 15 years? And how do you compare it with laparoscopic sleeve gastrectomy?
This is very important questions for new procedures. I tell the patient and also the fellows, and including all the doctors, how bariatric surgery really works on the patient is because we change the patient's hormones. It's not about we restrict the patient. So when you look at the history that we present today, those like a BBG, like a gastric banding, like a plication only, it all disappear in the history. It's not because we want to changing to new procedure. It's because this procedure don't work at long terms. Because the patient hormone was not changed. We did not change the hungry feeling. We did not increase society. The patient is suffer from they want to eat, but they cannot eat. So they change their diet to adapt, become a new behavior that they still want to become obese. So for ESG, I think this is internal plication of stomach. We did not cut anything. It means you did not reset the cell signals. So it will fail. It just maybe works in 1 or 2 years. But after that, 3, 4 years later, it fails. And very fortunately, for only restriction procedure like the BBG, gastric banding procedures, plication, it works in some cases, but only about 1/3. Another 2/3 patients in long term don't benefit from these procedures. But if you look at the sleeve gastrectomy, gastric bypass, or the other sleeve plus procedures, it almost can cover more than 70% more patients can have the good long-term results. So I think this is a definite different way that we treating the patients. But very difficult that we abandon it totally because the patient's concept, they don't accept cutting the stomach. Whether in the future we can have some modality, can change the hormones, but without cutting stomach, without bypassing small bowel, to decrease the complication rate from the cutting and bypass, then that would be the number one, the best option for the patient. But right now we don't have. So I think only rejection procedures without resect the GI tracts or bypassing one, it means no hormone modulation. Then it means that the long-term result is there.
Yeah. Thank you. Thank you very much, CK. I'll ask Kanagwal to come in, please. You are muted, Kanagwal.
Thank you, Professor CK. It's been a lot of learning for all of us. Before we close, I'd like to have a quick question. I'm sure you should be also watching up, and I'm sure you may be doing on your side the role of microbiota and role of fecal microbiome transplantation. Do you think it will be a game changer in the near future for a weight loss procedure?
It means fecal transplantation.
Exactly. Yes, sir. Yes, Professor.
In the beginning, this is the hope of gastroenterologists, that they thought that the fecal transplantation can help. But I think the hope is gone. Right now, the data showing that it don't help in the weight loss because the fecal transplantation in humans, we cannot change the behavior of humans. It can be proved in rats. It's because the rats, the eating behavior was controlled by us. You give the very simple food. But for humans, the microbiota of the colon, in fact, is coming from your diet. So if you change your diet, then you change your microbiota. But if you change your microbiota, you did not change the diet, it's still the same. So we have published one papers about the sleep and medical treatment in microbiota change after surgery and treatment. It's a randomized trial. In fact, it's showing the sleep gastrectomy case, the microbiota change is much better compared with the medical treatment arm. Even both can get the weight loss. I think that is because sleep gastrectomy case, the patient's diet become much simpler compared with the medical treatment arms. So I think for microbiota, it's just some use as a supplement. But if you treat this as a hope for weight loss, I don't think that is good help.
Thank you, Professor CK. I think all good things have to come to an end. It's been a lot of learning for us. And on behalf of all of us in IAGES, we look forward to have you physically in India in one of our programs and to watch your skills being transmitted live for the benefit of our students and the young surgeons. Thank you, Professor CK. May I now have the honor of inviting our Secretary, Dr. Ishwar Murthy, sir, to give and propose the vote of thanks. Over to you, sir.
Thank you, Kanagwal. My dear President, all the viewers of Docplexus today, I'm sure you all agree with me. This is yet another blockbuster in our series of the season 2 and session 7 of our prime time. And thanks to our President and also Kanagwal for getting the concept on this challenges and complications in weight loss surgery with one of the best in this world, Dr. CK Huang. And I'm very, very glad to see our immediate past president, Dr. Raman Goyal, who preaches and practices bariatric surgery day in and day out, moderating and getting the questions, very important topical questions to bring the best out of you today. So our greetings to you for having shared your moment with your pearls of wisdom, especially how you videos on GRD and also the video on how you manage the leak. They're all very rare videos, very enlightening to see. And also you nearly put the final nail in the coffin when you said the ESG has very little to play in the years to come. I think we have a lot to learn today. Thank you for sharing. I'm sure we'll be meeting you in various our IAGES platform in the coming years. As a honorary secretary on behalf of our president and the team EC, I wanted to share a few points regarding what's happening in our academic front. Viewers, you all know that we are already doing the online events because of the COVID with online FAGS, EFAGS, and oncology. But I want to know that I think we are going to go for on-site program. So this will be the year month end will be the last day before you apply for this. Then after that, we'll be moving on to our on-site event. And in the back end, to confront and also to treat the patients with the COVID. And we have the COVID task force. We are very, very glad to tell the final bureaus that we have collected close to 50 lakhs for this. And thanks to our chairman, Zamir Basa, and we will keep our fingers crossed that we will not be having a bad third wave, but still we are having 10 and more oxygen concentrators and also pediatric monitors are ready to be donated to various centers where they need through our IAGES EC members. So please, all of you, and encourage your patients to get vaccinated, stay safe. I'm sure the better days ahead. I think, as you can see, our IAGES has various fronts, both academic, social responsibility. From moving on from the online to on-site fellowship, we are going to go quickly in this coming month in September. And I'm sure all the senior members, if you can, happy to come for our false upper GI. This is an advanced laparoscopic course in all the upper GI procedure, going to be hosted by Randeep Vadhavan and his team in a very nice ambience in Vivanda by Taj in New Delhi. Please join in September 10th to 12th. The same month, if you are interested, especially youngsters, newcomers for IAGES, for a bonanza of both endoscopic, laparoscopic, basic skills, if you want to learn EFAGS and also FIAGS, you can come to Chennai and also the Sri Ramachandra Medical Colleges and Hilton, where the event is going to happen. And not only a gastronomic and also academic delights, I'm sure the hospitality, the Kanagavel, Balaji Singh would be wonderful. We are looking forward for that also. So already all these brochures and flyers are there, and I wanted everybody, especially for people who have already done the online program and waiting to get the on-site assessment. I just want to make a small announcement, and there are about close to 100 of them. Please call Dr. Kanagavel through mail. I already shared you a Google form. Even though the course is going to happen on 24, 25, 26, on 25th and 26th, these are the 2 days, that is Saturday afternoon onwards till Sunday lunchtime. We will be expecting you with no extra registration fee for people who have already registered through the online portal. So all you need to do is contact our organizing team, and I already have a list of people who have already consented. I'll share it with our organizing team. Rest of them, if you want, you can directly contact Kanagavel also. We'll do the needful. All you need to do is make your local arrangements for an overnight stay and the banquet, and all these hospitality is ours. And I'm sure you will enjoy. And it is just to give you from September, October, and until we see you all in February in Rajamundry. We are going to have a very busy on-site academic program, advanced laparoscopic and also the basic endoscopy laparoscopy. And people, if they are going to miss Chennai, the next time you can get a EFAGS or FAGS, a final chance, maybe only in Trichy and Dr. Govindraj. And as you can see, there are various falls programs. There is no plan as of now to have any online falls program but for the oncology. So please utilize this golden opportunity and see the site, and all these details are available in the website. Please go through leisurely, and if anything, you can always write to me, to secretary. And I, all on behalf of our president and the team, we look forward to see you on 10th to 13th February at Rajamundry for yet another 19th annual conference on convocation. And as I said, in addition to all these things, I think Dr. Ramesh Agarwala would be very, very delighted if you could join in our, all the research activities. The one is going to recruit people interested in inguinal hernia study, a common procedure. I'm sure every one of you may be doing open and laparoscopy. If you're interested, please contact Dr. Tarun Mittal or myself to recruit yourself in this study. And also, I'm sure next month early, we'll be sending you the application for the academic initiative prizes, the best JMAS article, best researcher award, and best thesis like last year. I'm sure you wait for me to make the announcement, and I'm sure the IAGES is spreading its academic wing, and I'm sure it's getting better and bigger, and we are going to host the 2024 World Congress in Kolkata, and for that also we are making some plans, and keep this place watched. We'll update you. And friends and ladies and gentlemen, all these activities, if you're not able to share this late time, you can watch all these videos either in the YouTube channel, Facebook, Instagram, Twitter, because our team with all our Sarfraz and Jaydeep and the team, Vivek Bindal, they're all happy to connect you with IAGES, with all the social friends, and IAGES in the website is with me. And sooner, I'm sure, we'll be just a touch of the button away with a mobile app. It's a matter of a few weeks. We'll send you the invitation during this opening ceremony. And until that time, stay safe. We look forward for more academic events. And again, we congratulate Kanagvel for yet another wonderful show today. And Professor Sunil Puppet for organizing it, and the Docplexus for coordinating for a seamless transmission. And our guest speaker, I think he was the master of the show, and Dr. Raman Goyal. All of you, and we all wish you bye-bye and safe stay. Jai Hind, bye-bye.
Thank you, Ishwar sir. And I should put on record, it is way beyond midnight at Taiwan. It's been a great effort by Dr. Professor CK. It is beyond 12:30 at local time, early in the morning in Taipei. Thank you, Professor CK, for staying so late in the night, and thank you for honoring our invitation over a mail. And I should also thank your secretary, Anita, who has been very kind, and we has been very closely coordinating with the entire team of the organizers for making the show a flawless one. Thank you, one and all. Thank you, Docplexus. And thank you, viewers. Good night. We look forward for yet another exciting event announcement soon. Good night, everyone.
Thanks, CK.
Thank you so much.
Bye-bye. Thank you.